So for in the morning, we will start with the
Yes, and today in the morning we have many interesting topic that we would like to talk today. And for the first topic, from theater to the voice, and from the voice to theater again. Okay, from the Siriraj Hospital, please welcome Dr. Voraboot to present the critical view of MPO 10 Golden Rules.
Thank you.
Thank you very much for, I would say, the greatest introduction in my life. All right, good morning, everyone in here at the venue and also in the Zoom platform. First of all, I would like to thank PSU and Thai Hernia Society for the invitation. I'm truly delighted to be a part in this wonderful conference. In next 15 minutes, I'm going to talk about the rules for anyone who wants to perform minimally invasive inguinal hernia repair. Okay. So I have no disclosure. So let's start with this question. Why do we have to follow the rules? Why we need rules? So this movie, I think this is a good example to answer these questions.มีเสียงออกปะ I think most of you guys have seen these movies called Squid Game on the Netflix, right? There's a rules. If you wanna win and survive in this cruel game, for example, this stage in the game, you have to move fast enough to the finish line in order to win the game. And whenever the dots turn back, you cannot move. If you move, this will happen. Die. So if you want to win and survive in this game, you have to follow the rules. Okay? ไม่ได้ยินเสียงมั้งเนาะ Okay. ไม่เป็นไรครับ Okay, so that's a good example. That we need rules and you have to follow the rules. Otherwise, you can die and catastrophe could be happen. And another, in our surgical life, one of the most famous rules for anyone who want to perform the lap chole is to achieve the critical view of safety. So you have to dissect both anterior and posterior of the collar triangle nicely to see two structures, which are cystic artery and cystic duct, before you're cutting anything, in order to prevent the common bile duct injuries. Okay, so here's the view, CVS view, that have been proposed by Dr. Strasberg in 1995. And then come back to what is the critical view of myopectoral orifice or MPO. So this is the definition, the appropriate exposure of the anatomical area that must be attended before placing mesh during the minimally invasive inguinal hernia repair by following presented step, which I mentioned later. Okay, this concept was proposed by Dr. Hoge, Jayes, and Edward Felix in 2017. So let's see. This is what I'm talking about is critical view of MPO. Critical view of MPO. And the reason why we need to achieve this critical view of MPO, because we found lots of recurrence if we couldn't achieve this view. Many causes that result in recurrence include insufficient dissection and overlapping of the MPO. folding of the mesh, missed hernia that we couldn't identify during surgery, missed lipoma of the cord, lack of parameterization, the elements of the cord, inadequate fixation. Initially, we slit the mesh that because we believe that it can prevent recurrence, but actually no, cause more recurrence and more pain. And finally, inadequate mesh size. So all of these cause recurrence. So that's why you have to achieve the critical view of MPO. But before I get into the details of 9 or 10 rules of the critical view of MPO, first concept that you have to understand that I mentioned yesterday is the zones of the section of the preperitoneal space. We divided into 3 zones, okay? Zone 1, the lateral zone, zone 2, the medial zone, and zone 3, the epigastric and major vessel zones. So as I mentioned yesterday, in TAPP surgery, you have to get into the zone 2 first, right? And then for TAPP, either zone 1 or zone 2, but both TEP and TAPP, the zone 3 is the last zone that you have to get into because this is the most difficult part and can cause complications. All right. So this is a really nice video demonstrate the critical view of MPO. I think in the original articles of the critical view of MPO, there are only 9 rules, okay? But after that, some surgeons, they develop into 10 rules, which I mentioned later, okay? First is to identify and dissection the pubic tubercle. You cross the midline, okay, to the other side. Second, you have to rule out the direct hernia and remove all the suspected fat at the Hasenberg triangle, okay? Clear the direct defect, okay? And then move to the third step. Dissection at least 2 centimeters between Cooper ligament and the bladder. This part is very important if you want to get any mesh rolling or migration because that's caused by the bladder distension. So you have to dissect pretty deep down there and dissect between the Cooper ligament and iliac vein to identify the any femoral hernia or not, okay? Okay, and then the 5th rule, dissect the indirect side and, you know, peritoneum sufficiently until you clearly identified the cord elements and it lie flat, okay? The 6th rule is to identify and reduce the cord lipomas. I think some surgeons, they didn't do identification of the lipoma and it caused recurrence. And then the 7th rule is dissect the peritoneum lateral and inferior well behind the mesh border. This is the most important part because most of the recurrence you didn't dissect the hernia sac or peritoneum like above the mesh placement. And then the 8th rules is provide mesh curving and any fixation should go above iliopubis tract, okay, in order to prevent injury to both triangle abdomen and pain. And the final step is placement of proper size of the mesh, at least 10 by 15 centimeters, and make sure there's no keys or folds before you desufflation, I mean the operative field. So again, this is the summary of the 9 rules or 9 steps of critical view of MPO. Okay. And then before I show you the real video about how to achieve the critical view of MPO, 2 things that you have to remember, although you don't have robot, okay? When you dissect clearly like that, so the mesh overlapping, you need at least 3 to 4 centimeters. Okay, apart from all the defects, like in the medial, you need 3 to centimeter from the direct defect, femoral defect, and the lateral, you need about 3 to centimeter as well, apart from the internal ring. So basically, that's why we need at least 10 to 15 centimeters in order to cover all the myopectoneal orifice. Okay, and again, try to put less tacker. Or some cases, you don't have to put any fixation. You just leave it alone there. Okay, especially if the hernia size is less than 3 centimeter or M3, according to the hernia classification. Okay, and try to avoid any fixation below the iliopubik tract. Yeah, this is iliopubik tract. Okay, the blue line here. So shouldn't do more than 6 tackers or fixation. Okay. All right. So I'm going to show you the video that I performed with Dr. Sripong. Actually, I was here to help him to do first robotic inguinal hernia repair. This is his first case. Okay, you won't believe this is his first case. Okay, he did a really good job. Okay, so actually this case is bilateral hernia. Okay, and then we start with on the right side first. Okay, you can appreciate that the hole is right there, the direct defect there. So for the first step, you have to create the peritoneum flap at least 4 centimeters, okay, from the internal ring. Okay, I believe that maybe in Japan they do a less flap length, they do only 2 centimeters, but I personally believe that greater length of the flap can put the mesh properly. Okay, and then I start with the zone 1 first. As I mentioned yesterday, that we keep close to the peritoneum, okay, and push all the shiny fiber that call TF or transverse fascia above, okay, and once you dissect until you see the level of the epigastric vessel, then you are going into the medial compartment. Okay, the medial compartment is different. You have to go above the shiny fibers, or maybe someone called the intermediate fascia or posterior TF fascia, whatever. Okay, there's a reason why the lateral compartment we go below and why the middle compartment we go above. They all because we want to protect the nerve injury. Okay, on the middle side, all the neurovascular bundle runs beneath the TF fascia. So that's why we keep the TF fascia along with the bladder in order to prevent the mesh erosion or irritate to the nerve. And for the lateral side, all the nerves run along the muscle. That's why we keep the fatty tissue or the yellow stuff against the muscle. Okay. And once you achieve both lateral and middle compartment, you can divide the intermediate fascia. And then when you divide it, okay, you can go through the internal ring. So this is the first step of the critical view MPO. Dissect medially until you see the linea alba, the midline, okay? And then you can appreciate the cubital ligament. You see the cubital ligament, right? And the dissect deep into the richest space, at least 2 centimeters, okay, in order to get the proper mesh placement and avoid the mesh malposition from the distended the bladder, urinary bladder. Now you can appreciate the collateral between the iliac system and obturator system called coronal modis there. That's run over the cubital ligaments. Okay. And then step 4, try to identify the femoral orifice, make sure there's no femoral hernia defect. And then move immediately to dissect the peritoneum and make sure that you can appreciate view that the vast difference run across the iliac vessels. Okay, that's the appropriate dissection of the peritoneum. Otherwise, if you cannot get this view, can cause the recurrence because the hernia sac still go underneath the mesh. And then you move to lateral to dissect the allopubic tract. So that's the triangle of doom there. Okay. You can appreciate three nerves. First is genital branch of genital femoral nerve, and then femoral branch of genital femoral nerve, and lateral cutaneous branch. Okay, here's the TAPP sling. It's a part of intermediate fascia that encircle the cord structures. So you can see if you have this principle or basic, no matter how big of your internal ring or in indirect side, you follow the TF fascia that encircle the cord structure. So, and then when you get into the level internal ring, you just divide the TF sling, and then you can get the hernia sac afterwards. I personally try to close all the hernia defect because I do believe that it can decrease the seroma. But again, this is my personal experience. On the left side, we also did the same steps, okay? All right. And then I think we have a really good view of the critical view of MPO now. Okay, time out now, okay. Can I sing one more song left? No? And then, okay, and then I use the mesh. Mesh that I use basically is polypropylene mesh. I'm not a big fan of anatomical mesh. I still using the regular mesh. So polypropylene mesh, and then cut it into 10 by 15. And then I fixed first at the Cooper ligament, and then the most lateral side. And then after that, left and right of the epigastric vessels. And if the patient got really big direct hernia, I also put one more at the rectus muscle, the most medial part. Okay. And whenever you do both sides, don't forget to overlap the mesh too, like this, couple centimeters, and put one stitch to fix both meshes. Okay. ใกล้จบแล้วครับแป๊บเดียวครับ And then once everything all set, so you close the peritoneum. Okay. Okay. Vlog is really nice too, so I love Vlog. So use Vlog 3.0 to run to close the peritoneum. Some surgeons they remove the air in the preperitoneal plane because they believe that it can affect like a sandwich effect in TEP, so the mesh may be fixed more proper. But again, there's some surgeon experience. Okay. So ladies and gentlemen, this is my conclusion. Let's have a look at two papers. So this is a very nice paper, the original article on the left side, and then on the right side is the recent paper that published in surgical endoscopy. Actually, it's pretty the same. On the left side is 9 rules, on the right side is 10 rules, but in the detail it's pretty the same. Okay. And then here's the result. If you follow the rules, you survive. That's it. So ladies and gentlemen, thank you very much for your attention. And you guys are welcome in next year. We have a bariatric surgery, surgical conference in Rayong City, not far from Bangkok. So you guys are welcome to join us. Thank you very much.